Well, now I think we can start the session. I would like to invite on stage Dr. Akihiro Seita. He is the Director of Health Program in the UNRWA, which is the UN Relief and Works Agency for Palestine refugees in the Near East in Jordan. Dr. Akihiro, he will talk about the access to hospital services for Palestine refugees, the challenge of UNRWA in difficult times. Dr. Akihiro.
Good morning. Thank you very much, Dr. Hani and everybody, to invite me to this wonderful International Hospital Federations Conference, and thanks to the government of Oman for inviting me to this conference. My name is, as written, it's written there, is Seita. I work for the United Nations Relief and Works Agency for Palestine refugees, and I live in Jordan, in Amman, work for the Palestine refugees. You may wonder that why I am here to talk this International Hospitalization Federation Conference, and then that please don't worry. I'm the one who wonders most, so why I'm speaking here. So today, allow me to speak about Palestine refugees. Today that we have 5.6 million Palestine refugees in this part of the world. As you can see, Jordan, Palestine, West Bank, and Gaza, Syria, and Lebanon. And largely the Jordan, followed by Palestine, but also we do have Palestine refugees, Lebanon and Syria, since last 70 years or plus. And 1/3 of them still live in the 58 refugee camps. So this is probably the largest refugee populations, together with the Syrian refugees. There's no competition for this. There should be no competition for this. But at the same time, this is the longest, by far the longest refugee status in the world. Next slide, please. Sorry. So allow me to introduce my boss. He's a Palestine refugee I met in Jordan. His story is Palestine refugees story. In 1948 spring, there was a first Arab-Israel conflict. His area, historical Palestine, was under the risk. And so his brothers, sisters, his parents, probably his grandfather, parents, left the home, brought something minimum essential, papers, closed the door, locked the door, and left his house. And then everybody thought that we can come back in a couple of weeks, if not a month, to his original house. And after 70 years, he never returned. He went to the West Bank and he went to Jordan. I met him in Jordan. If you can see in his left hand, that's the key of his original house in Palestine. It's a big key. He still keeps this. The paper in front of him is a registration of his house by the then government in the Palestine. And his sand for his house. So he has never been returned. He has been refugee status 70 years. This is totally not acceptable. Next slide, please. But today, this is a conference for health. So I speak about the health of Palestine refugees. If you ask me what is the leading cause of death for Palestine refugees, it's non-communicable disease, lifestyle-related conditions, including diabetes, cancer, high blood pressure, cardiovascular, and the smoke-related lung disease. And so it is, of course, that the maternal and child health conditions are important, and of course, conditions of injuries are important, particularly the war-affected Syria. But nevertheless, the bottom line is that the non-communicable disease killed the most in the Palestinian refugees. It is not because they enjoy the fantastic high-calorie food. It is simply because they are poor. They do not have access to a healthy life. Healthy life meals, fruits, meat, expensive. So they eat a very staple food, and then no exercise, because gym is there but expensive, and they smoke a lot, so they become a non-communicable disease. So that is the nature of the health in the 21st refugees. It is not only Palestinian refugees. Syrian refugees, the same. Many refugees in the current contemporary world. Non-communicable disease is very important to remember. But disease is not the only one who affect their health. Next slide, please. This is the photo I took in 2014, summer in Gaza. There was 50 days of very heavy war in Gaza in 2014, and I went there in September. This is a girl in Nam, 16 years old. This is her house. She lived there with 7 members of her family, and you can see that there's no walls of this is the second floor. And then there's a lot of destroyed houses and also big holes for the bombardment near her house. So this affects her health. This affects the health of her family. So disease itself is not the issue for the health for the refugees. Next, please. This is UNRWA, United Nations Relief and Works Agency for Palestine refugees. I work. And it was established in 1949 to take care of the Palestine refugees, occurred in 1948. And then we provide the services like education, 700 schools, 500,000 students. It's pretty big. In the United States scale, it is next to the California and the New York State. So it's quite big services. Health, which we are working, is with 144 clinics. It's basically we do clinics and no hospitals in principle. And we have 3.1 million patients visit every year, or the 9 million visitors, because everybody visits more than once. And we do the relief and social services and emergency support. In Gaza, we have 1.4 million Palestinian refugees there. 1 million are relying on the UNRWA's food support. So this tells how bad the situation in Gaza is and the protection of this. The one important thing is that the UNRWA was established in 1949, started working in 1950 with only 3 years mandate. So in those days that the world thought that the Palestinian refugee issue should be solved in 3 years' time. And I never counted how many 3 years we passed. But this year and this month, next week, there is a discussion in the United Nations headquarters to renew our mandate. So we renew, inshallah, our mandate for another 3 years. This is good. But personally, I think this is a shame for the international community. Next, please. So back to the topic of this conference, universal health coverage for Palestinian refugees. The context we live in is that the NCD crisis, health crisis, huge number of NCDs, and the human security crisis. As I shown the photo from Gaza, society, economy, and the equally important, if not more, is the dignity is lost. That's very important for human beings to live. In such a context, we provide primary health care. It's first and foremost that we have 144 clinics, but we work with the hospital to make sure that the essential health service or hospital care will be available. Next, please. So first one is access to primary health care. Again, as I said, within the NCD crisis, and what we have is only primary health care center. We don't have hospitals. So what are we going to do? We do two things to respond to this. One is family medicine. We introduce family medicine approach. And the second one is electronic medical records to take care of the longest continuity of care. Next, please. This is a very simple mimic animation of what we did. On your left side is our primary health care center before the family health team introduction. When the Fatima, if you can see, there's one lady and the husband Mohammed. This is my innovation. It's not real. But nevertheless, with the 6 children, which is a reasonably average size in Palestine. And when they go to the clinic, there's a service delivery points based on diseases. NCD clinics, diabetes, maternal child health on the top, and also general clinics like back pain, all these kind of things. And so that whenever Fatima comes, she goes to the clinic service delivery point based on the conditions she has. So this is a disease-centered approach. So there's a diabetes Fatima, back pain Fatima, pregnant Fatima. But there's no Fatima, per se. And the trouble with us is that we have different medical records in these ones. We abolished this totally, and they introduced family health team, took the idea from Toronto, Canada. And then that a couple with doctor and the midwives, and then that they provide the same care regardless of the reason of the Fatima visit. So that Fatima goes always to there. They have my doctor, my patient relationship, or person-centered approach. This is what we did in all the health centers in UNRWA in the last several years. Next, please. Next one is the electronic medical records, e-health. This is house-made, in-house made. We have a fantastic IT people who developed that e-health. It's internet-based, and all clinics are connected in one server in Amman. And then this is the photo I took from Syria in August this year. And it's wonderful that in Syria that we have electronic medical records, which is connected to this. And it could generate 22 reports to run the health services, and also that it has 3.6 million patient records by now. It's quite the largest and good. And we published a paper recently for this one. So next, please.
علي الكوفية
Intermission.
علي ودولح فيها غني عتابة وميزانة وسامر فيها علي الكوفية علي
محمد عساف صوته حلو لازم يفوز.
فرحان؟ اسم الله عليك يما يا حبيبي، ليش بتكح؟
صار شارب 3 كزايز دوا كحة ولساته بكح.
خلينا ناخذ على الدكتور.
ليش الدكتور؟ بكرة بطيب لحاله، خلي عنده مناعة. وبعدين مش عارف يسمع البرنامج من الكحكحة.
يا زعلت في هالسيكارة ارحمنا، انت بتضر اللي في بطني.
هو أنا اللي بدخن ولا أنتو؟
ما سمعت في التدخين السلبي خطر أكبر من التدخين العادي، وبيعمل قصور في التنفس، التهاب في الشعب الرئوية، وبيعمل ربو. يابا إذا بدك أكون سليم وما تقتلني بسيكارتك اطفيها هسا.
حكى ابني، حكى.
مين أهم، سيكارتك ولا حياتي؟
أنت يا حياتي، خلص من هان ورايح، لا تدخين بعد اليوم.
يابا بدي مطاطا.
خد.
It will not happen, but I think the message is very clear. And then that I don't know, giving lollipops is a good end, but whatever. But this is pretty good ones. We work with Zar and Hador in Jordan. They make animation. So back to bit serious talk. So this reform produced a reasonably good result. First is satisfaction. We did a survey for the patient. Patients are okay. That's not a major. That's important, but that's not a major issue. The major issue is the staff. And the majority of the staff either smiling twice or the smiling once. Of course, there's some people who are not happy, but in any organizations, changes cannot make everybody happy. That's not the problem. But the majority make happy. That's a good change we brought. And this resulted in the daily medical consultation. Our doctors are very busy. In the past, they used to see 100 patients. Mission impossible, but they did so. But because of the family medicine approach, that they avoided the repeated visit, but also they avoided the shopping of the doctor. So the patient have to come to my doctor, not go to the other doctor. And the antibiotic prescription rate went down, and I think WHO says less than 30. And the 4 times antenatal care visit is more than 90%, which is much higher than WHO's target of 80 or 85%. So it's a good result. Next, please. So moving ahead. One is that introducing mental health, because as you have seen that, the photo from Gaza, mental health is the issue. There's no need to explain why it's a problem. So with the help of WHO, thanks to Dr. Madali, that we introduced a WHO mental health gap in our health centers. The idea is to train all the doctors and nurses and midwives, everybody for the mental health. So not only to provide the clinical side of mental care, health like depression care, but also addressing the entire care, like mothers who may have that post-partum, post-delivery depression, that kind of things. And second is family medicine training. Family medicine, we introduced family medicine, but they are not family medicine specialists. In this part of the world, family medicine is a 4-year specialty. We have 500 doctors, we have no money, no time, no nothing to send them for 4 years. It is not possible at all. So in collaboration with the United Kingdom institutions, we introduced 1 year on-the-job training to train them. And this is the first cohort, graduation ceremony. Very proud, they are very proud, very happy, decorate, put the same clothes and come into the ones. And we published a paper on the British Journal of General Practitioner Open. Next, please. Innovations. Smartphone application. This mother have the maternal child health smartphone application on her left hand, show that the hard booklet, which we introduced with the help of Japan. It's a maternal child health booklet. Now it's in a smartphone. And then that she is showing how happy I am. I have this in my one, I can show it to you, but unfortunately I'm not pregnant, so I cannot show it to you. But once I become pregnant, I can show it to you. Inshallah. And we are moving towards that NCDA smartphone application now, which we are in developing now. Hopefully it comes by the end of the year. On the right side is research is very critical for us to tell the world that how our staff are great. And publishing lots of papers, trying to publish lots of papers. The one is showing the recent publication in the health policy and planning, health system resilience in the face of crisis, analyzing the challenges, strategies, and the capacities of UNRWA in Syria. And this is done by the Queen Margaret University in Scotland and the American University of Beirut of Lebanon, and they're providing this to the services. Yep. So that's the research. Next, please. So hospitals. As I said, we run the primary healthcare centers. We have only one hospital in the West Bank. This is another issue. But we don't run the hospital. So we provide the access to the services by paying to the hospitals or the patient whenever they go. We reimburse them based on the contract we have. This is very important for the Palestinian refugees to get access to the hospital services from the contracted hospital. But this is always very difficult. It is challenging. And in the past, I just want to be honest that we've been doing somehow what we've been doing. Not always strategic. Next slide, please. So this is the reality of what we are living in. And the refugee population on the right pie chart shows that the largest refugees are in Jordan, followed by Gaza, West Bank, Syria, and Lebanon. Lebanon accounts only 9% of the entire refugees. At the same time, hospital expenditure-wise, we spend a lot in Lebanon. More than half goes to Lebanon out of $20+ million annual expenditures. It's simply because that in Lebanon, because of many complicated reasons, that they do not have always access to the government hospital services, and they do not have health insurance. So we are the last resort to make sure that they have access to the life-saving hospital care. So this is the correct thing to spend the money. In case of Jordan, for example, thanks to the fantastic collaboration Jordan Ministry of Health, they give the access to the majority of the Palestinian refugees. They are also having a Jordan citizenship. So in Jordan, we spend the least. It doesn't mean that they do not have access, because thanks to the Jordan government, they have access. Lebanon, no. So that's the reason we spend this. But this is a reality we live in. But are we managing this well? My answer was no. Next, please. So this is the hospital expenditure in Lebanon in the last several years. It drastically doubled from 2011 to 13, and then that 2014 and 15. And we end up the huge crisis in 2015 simply because we spend more than the budget. So in the middle of 2015, that they called me from the Lebanon office to me in Amman, saying that we are in crisis, we have no money to pay to the hospital. I said, what? And of course, my boss got pretty angry. So I have to take the next flight to go into Lebanon and stay with the Lebanese Palestinian refugee people in Lebanon in our office and ask them what's happened. And I tell you that we didn't know what's happened. That's the problem. We have no idea why you're spending lots of money and for what. What we know is that it looks like we're spending money, but we have no idea exactly why the cost increased. That time I consulted WHO and they asked many questions, and then I end up with Eric. Met in the Geneva and explained to him, what is this, how can you do, can you help me? And he gave me, of course, right answers, correct answers, strategic advice, but he told me one thing, which I never forget. Seeing this situation, Eric simply said, Seita, you become the ATM machine for the hospitals. You remember that? You told me that, and it's correct. We became the ATM machine. Hospital needs money, go to us, put the ATM machine to cash. No. But that's what really the problem. So we have to solve this. Because that's a very critical moment, because this is a cost driver, and if we haven't solved this, what the office is going to do is he solved myself, so I could disappear. So what we did, next slide please. First, situation analysis, as usual. Why? Of course, the bottom line is that the Palestinian refugees in Lebanon do not have health insurance, less than 5% health insurance. So which means they are very difficult to go to the hospital. So we have to spend. And they do not have, in principle, access to the Lebanese Ministry of Health hospital because of totally different reasons. But also at the same time, we have very limited capacity in managing hospital payment. Weak contractual management. We have a contract, but we are not exactly following this. And we have a payment, we are paying according to a contract, but not always exactly what we need to pay. And then no data management at that time. When I ask why we are spending more, they say we are spending more, nothing more, which internal medicine, surgery, whatever. So that's a problem. So our response, next slide please. The first thing is leadership. I just want to, again, honest, that we change the leader in the health in Lebanon. Simply because that's the only thing, that's the first thing we got to do. The current one is very strong, very committed, and he leads politics very well. I think that's a very important part. Secondly, we put the monitoring mechanism. In Lebanon, we divided Lebanon from our administrative reason in 4 areas, and in each area we put the hospitalization officer. His or her job is going to the hospital every day, check the admissions, check the clinical diagnosis, check the payment, everything. And so that we can check that we are using the hospital rationally. To help him, we developed, Gloria, who is sitting in the audience, my colleague, developed the data sets so that we can have more detailed data sets. And the fundamental thing is that the health centers referral post, family medicine, and the gatekeeper role of health centers is improved. And then that collaboration with Palestine Red Crescent Hospital, which is our strategic partner, and so that we work with them so that we can refer the patient as many as possible because they provide the care with a comparatively reasonable price in Lebanon where everything is very expensive. So next, please. This is a hospital monitoring data set Gloria developed. It's a web-based situation, web-based data set. And then that so that people can go to the hospital with this and enter data on the spot, name and diagnosis, everything, including not only the medical, clinical part or the financial part after discharge. And thanks to Lebanese Ministry of Public Health, they use ICD-10 level 2 diagnosis, so we simply use that one too. So this gives us a very clear picture of where we are spending, how we are spending the money. And next, please. And of course, two people who are helping the registry hospitalizations. They are not the head of the one, but they are staff helping us. They didn't know that I took photo, and they do not know that I'm showing this to you. But I'm very proud to show this to you because they are working very hard for this. On that day, what they are discussing is why this hospital costs us more in the same procedures than the others in terms of unit price. So they look into detail why and why. I think that's a very good thing. So that's the reason I want to show to them, to show my appreciation to them. Yeah, next, please. So we managed to reduce the expenditures from 15 to 13 million, $2 million reduction. But it is not the reduction of the access to the services. It is rationalizing the referral, that's what we saw. And also that the reduction of the days of the stay in the hospital. So they're rationalizing this. We checked the data set, and those who are in need of hospitalization did go to the hospital. So it's not kicking some people out of the hospitalization access. It is rationalizing this one. So that's a good one, thanks to everybody, and then the reason I can come here. Yeah, next, please. Another intermission.
خضرة جعان مش قادر، عصافير بطني بتزكزك، ومن الصبح ما حطيت لقمة في ثمي، هاتي طعميني إشي.
هذا عشانك ما بتمشيش، صرت مثل البالون، شوية وبتفكع. طول يومك قاعد قدام هالتلفزيون، وفي الشغل قاعد ورا المكتب، قم امشي يا زعل، اركض، ارمح، خفف وزنك وأكلك، إن مشيت كل يومين نص ساعة كلبك بيبكى شباب.
بيبكى شباب؟
الحقني.
امشي واركض بالمعقول.
بتبكى شباب على طول.
Thank you very much. Yeah, if we can lose our belly in this way, I think life is wonderful. But nevertheless, message there. What we're doing new is within the context of NCD crisis, human security crisis, and we have only contracted hospital. We have contracted hospitals. Only one thing we have one. But what we did, one is improve primary care. It's person-centered family medicine, referral, and also the gatekeeper functions. And the hospitalization support policy, which I will explain in the next slide. But the rigorous monitoring, contract monitoring, like what we saw in Lebanon. So this is what we are doing now. Yeah, next, please. So our policy is who to support, what we support, and how we support. Who to support is those who are in need. Those who are poor, non-insured, or no alternative, no other path to go into the hospitals. And also the one with the risk of a catastrophic health expenditure, like a cancer treatment in Lebanon. It's a total expensive. We pay the difference. How? Which one is basically the urgent and clinical need, acute life-saving care. Of course, we do something else, but nevertheless, that's a priority. How is hospital negotiate prices? In many places that we use the government tariff for the hospitals. And they start negotiating, please, and more, this and that, and they try to reduce the negotiated prices. That works well, but the trouble in some places is that the private hospitals do not follow the government tariff. And so that's a major difficulties. And the patient, we have a cost sharing. So that's what we're going to do. Next, please. Apologize a bit the disturbing photos. That we have a new reality. In Gaza, because of the economic conditions, people start making demonstrations along with the borders with Israel since last March. And then because of the economic conditions so bad, and so that they really want to go back to the original land and then that regain the dignity in life. That's the reason they call it Great March of Return. UNRWA do not support this demonstration because of the risk and because of the political reasons, but there is a risk. And because that the security is a most important part of the Israel government, and we have a large number of injuries. To date, we have more than 30,000 injured, and then this is simply a majority of a gunshot wound. It's simply because beyond the capacity of any hospital combined in Gaza to manage. So what happens is that many patients came to us because hospital could not manage this. Up to date, we have more than 3,000 patients with gunshot injured or injured came to us. Like these photos I took in the health center in Gaza. You can immediately see this gunshot. It's beyond what the clinic can manage on the ankle, or the person who has a shot in the belly. It is also difficult for us to manage. But nevertheless, we have no alternative. They have no alternate, so we have to manage this. We improve ourselves with the help of the many partners, but that's a new reality. But it clearly tells us the hospital and the primary care have to work together. It's a supplemental. It's not mutually exclusive at all. So next, please. So having said so, our experience from our side is one is that in the access of a university UHC in the time of crisis, one is strengthen the primary care is critical. It's a must. It's basically this is what we have to do. It is to protect the community from the increasing disease burdens, but also that the referral role or the gatekeeper role to the higher level of care, because that's what we really need to do in primary care. And also at the same time that the supplement in the hospital care, like what we saw in Gaza. So it's mutually dependent. At the same time, collaboration with the hospital is a must, because this is a protect access to life-saving care, because people need hospitalization service. There's no question about this. And the contract management and the data management is critical for us to make sure this collaboration works for the mutual benefit. And the financial management is always there. We have to purchase the service at the least cost I want, but hospital wants to sell the service at the highest cost they want, and so that we have to work together. It is very difficult, but it's not impossible. Next, please. If we translate this into the bit wider scope from our experience, that the bottom line is that people need both hospital and primary care services. Like in Gaza, for the care they can avail, either this is from hospital or primary care, it doesn't matter. They need such care. But we have to respond to we have to be responsive to the changing disease burden in the community. You can just imagine that if the young girl with the diabetes type 1 crossing the border from Syria to Jordan or Syria to Lebanon, the access to insulin is a life-saving. And that is a must that our health care provider should provide, either hospital or the clinic. And then that is what is mean by the refugees' health in the 21st centuries. And again, that the service demand is expanding, so primary care clinic or the hospital alone cannot manage this. And the finance is a challenge, still very challenging. And the strong management innovation is important because that the people need care, but somebody have to pay. How we can pay, that is a challenge we have. So having said so, last slide, please. Let me share my dream. On the left side is UNRWA without borders. This is my personal dream, which is not within our mandate, so it doesn't take place in reality yet. But we managed to send our 2 doctors in Rohingya refugee camp in Bangladesh with the help of Japanese NGO last year. They stayed there 1-2 weeks. They provide the care. And Dr. Ali in the photo is an ex-staff who retired recently. He went there, stayed there, and provided care to Rohingya refugees. When he came back, I asked him, how's the situation, how's the refugee camp? His answer was heartbreaking. Dr. Ali was born in the refugee camp in the West Bank, grew up in the refugee camp in West Bank, went to the UNRWA school refugee camp, and in 1967 he moved to Jordan, and he went to the medical school in Spain with the help of family. And they came back to Jordan, did a practice, and they work UNRWA, and they retired. This is a very fantastic success story for Palestinian refugees. What he said, Seita, what I saw in Rohingya refugee camp is exactly what I saw in the West Bank refugee camp when I was a boy. Nothing changed. I simply understand how they live. I knew how the street behind the house is exactly the same as the refugee camp in the West Bank. And the way that they gather, they try to search for the life is exactly the same as the West Bank refugee camp in the 1960s or 50s. This is truly heartbreaking, but totally moving. So having said so, hospitalization management is a headache, nightmare, extraordinarily difficult for many of us. How to run the hospital, not only how to run the hospital, but how to manage hospital within the health system. I think that's the reason we are here. Is truly complicated. And it's not only the stable condition, but the time of crisis, it becomes more and more important because the entire pie is small. So that my message to the International Hospital Federation is, why not the IHF without borders? Because there are many people who need support in the world in the time of crisis, and this is the greatest gift that the world can give to those who are in need. Thank you very much.